Thank you for joining us today for our webinar on treating anaphylaxis and what you need to know about Benadryl. I am Jennifer Gertz, Executive Director of Food Allergy Canada. Our Back to School campaign, Be Prepared, Be Confident, is underway, and as part of that, we have educational programming to support confidence in treating anaphylaxis and reinforcing epinephrine, your EpiPen, your Allerject, or your Emerade device, and not antihistamines as being the first-line treatment. For those of you who signed on early to the webinar today, you would have had the opportunity to watch one of our recently created video assets on what is anaphylaxis. Rest assured, if you didn't sign on early, we'll share the links for that with you so you can review it and share it with others. Now, today's session focuses on the commonly asked questions around the role of antihistamines. What is the role of antihistamines in treating allergic reactions, including anaphylaxis? And more specifically, many ask about Benadryl, something that we found in our parents' and grandparents' medicine cabinets, yet we hear some conflicting information. Is it useful? Is it harmful? This webinar digs into that topic and to the topic overall of antihistamines. What is their role? What are the differences between the available options? We will touch on signs and symptoms of anaphylaxis, but the majority of the session will focus on antihistamines. At the end of the webinar, if you're looking for more information on signs and symptoms, when and how to use the various devices, we have a slide that will direct you to links and to the additional resources that are available to further build confidence in recognizing and treating anaphylaxis. Before I introduce today's expert for the session, I want to note a few housekeeping items. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions on registration. There are some common questions that we'll tackle in today's session. If you have additional questions during the webinar, please submit them in the chat question box throughout, and we'll try to get to as many of those as we can. And this webinar will be recorded and shared on foodallergycanada.ca afterwards. So our expert today is Dr. Ann Ellis. She is a professor of medicine and chair of the Division of Allergy and Immunology at Queen's University. She holds the James H. Day Chair in Allergic Disease and Allergy Research. She is also the director of the Environmental Exposures Unit and the Allergy Research Unit at Kingston General Hospital. She's also the president of the Canadian Society of Allergy and Clinical Immunology and serves on the Joint Task Force for Practice Parameters, which represents the American Academy of Allergy, Asthma, and Immunology, as well as the American College of Allergy, Asthma, and Immunology. We are delighted to have Dr. Ellis join us today to walk us through her presentation and then take time at the end of it to answer our questions. So Dr. Ellis, thank you for finding the time. We're pleased you could join us and offer your expertise, and I'll turn it over to you.
Great, thank you so much for the kind introduction, Jennifer. And it's a pleasure to be talking to you about one of my favorite topics today. Two of my favorite topics, anaphylaxis and why I don't like Benadryl. So to get started, first and foremost, my disclosures, I am a clinician scientist and most of what I do is actually running clinical trials. So I do wind up with a lot of associations with the pharmaceutical industry. What's most relevant today is I will be talking about 3 epinephrine auto-injectors and that are made by manufacturers that are listed on this slide, as well as numerous antihistamines, and some of their distributors are listed on this slide as well. So first and foremost, though, especially if you missed Dr. Pejan's excellent pre-webinar, we're just going to review the immunology of food allergic reactions and what is it that actually happens. So once you've become sensitized to a protein, you form serum-specific IgE that recognizes that protein, or those little bits of that protein. And that IgE antibodies finds its home on the surfaces of mast cells or basophils. When you then encounter that allergen again, it binds to the IgE molecules, and that cross-links 2 of them together. And that cross-linkage is what leads to the mast cell degranulating or activating. and they release all kinds of mediators, only one of which is histamine, that cause symptoms that affect your blood vessels, the smooth muscle, and leading to symptoms that involve the skin, the lung, and occasionally the intestine, as well as other organ systems. So again, when we think about how to define anaphylaxis, when do you say it's anaphylaxis? Well, the best diagnosis we have right now, to keep it as simple as possible, is if you have the sudden onset of symptoms that sound like they're IgE mediated, and they're listed on the far side of the slide, and I will walk through those, that develop within minutes to no more than 2 hours after exposure to this antigen or allergen. The symptoms should involve 2 or more body systems, so skin. So if you see hives, swelling of the lips, face, or tongue, itching of the skin, particularly itching of the palms or soles of your feet. Respiratory can involve coughing, wheezing, shortness of breath, occasionally chest tightness or chest pain, throat tightness, having a hoarse voice, nasal congestion, and even hay fever-like symptoms can happen early on. It's an early symptom. And we also look at gastrointestinal symptoms such as nausea, abdominal pain, vomiting, and diarrhea. Cardiovascular symptoms would include feeling pale or weak, having a low blood pressure, or in case of just recognizing the symptoms, feeling dizzy and passing out. And other symptoms would include things like a sense of impending doom, and occasionally metallic taste or uterine cramps in females. So you do need to have at least 2, or you can have one severe symptom upon known ingestion. So if you've got something that you know you're allergic to and you know you ate it, and you drop your blood pressure or pass out or have difficulty breathing, that's enough to call that anaphylaxis. So when we go to treat anaphylaxis, Jennifer already alluded to the fact that epinephrine is the treatment of choice, and here's why. If you look at the effect of epinephrine, it helps to open up the airways for people who are having difficulty breathing. It helps to raise your heart rate and blood pressure to counteract all those cardiovascular manifestations. It'll increase how strong your heart can beat. But most importantly, it acts on mast cells to actually stop the ongoing reaction. So there's nothing else that actually halts mast cell degranulation in the treatment of anaphylaxis except epinephrine. In the skin, it'll help to reduce hives, and look at that, that's about the only thing that antihistamines are going to do for you in the setting of anaphylaxis. So again, the main reason why we want to make sure that people are getting epinephrine when you've met criteria for anaphylaxis is it will stop the reaction from getting worse, and it will actually halt the process. So why not just antihistamines? So I think I already alluded to this. Only epinephrine will stop mast cell degranulation, and we want to make sure that we're doing that. We have 3 Health Canada approved epinephrine auto-injectors. Everyone is very familiar with EpiPen that's been on the market for over 25 years. It's available in a dose that's 0.15 milligrams for children who weigh less than 30 kilograms. If you weigh more than 30 kilograms, you move up to a 0.3 milligram dose. Allerject is a different design. Again, it's a different shape, it's a little bit more compact, and it has a video audio cue. So when you take it out of its safety case, it tells you what to do. Also has the 2 doses, the 0.15 and the 0.3. Up until recently, we also had Emerade. It's on current recall in Canada, but it had the advantage of offering a 0.5 milligram dose. And all 3 of these products do have their own websites that give you instructions on how to use them, and offer the ability to get a refill reminder at the end of the year, but so can your pharmacies as well. So as I mentioned already, the first line therapy for anaphylaxis is epinephrine, and antihistamines will never replace epinephrine for anaphylaxis management. Many patients with food allergy or stinging insect allergy do tend to carry an antihistamine with them alongside of their epinephrine auto-injector in case they have a very mild reaction, and it doesn't meet criteria for anaphylaxis, or they'd like to take it as an add-on. So you've used your epinephrine, perfect. If you're really itchy, then it's probably okay to take an antihistamine as well. But if you've got the 2 or more organ systems, you're not doing just antihistamines, you're giving the epinephrine. But it's important to realize that not all antihistamines are the same, and we're going to talk about that a bit today. So this is the original title of my talk, which was just simply Time to Put Benadryl to Bed, but we do want to focus on the role of antihistamines in anaphylaxis. But really, I'm going to dive into a little bit of the safety issues with first generation antihistamines, Benadryl being the most recognizable and commonly used one that I think almost everybody, as Jennifer alluded to, already has in their medicine cabinet. So why are we talking about safety issues of Benadryl and other old antihistamines? Well, the Canadian Society of Allergy and Clinical Immunology released a position statement back in 2019. It's a very wordy title. I wish it just said, don't use old antihistamines, just use new antihistamines. But it is a position statement saying that we should not be using these older agents for the treatment of allergic rhinitis and urticaria. And we, as allergists, speak to the fact that we shouldn't really be using them for anything. And we did try to advocate with Health Canada back then to get it moved behind the counter. And there was a press release around this effort, which unfortunately wasn't successful, as you can tell. But it did lead to this embarrassing interview with me and Ben Mulroney back when it was pre-COVID, and the technology in my basement was nowhere near as good as his studio. But the question was, well, why now? Why are we suddenly complaining about Benadryl? Well, as allergists, we've known about the downsides and dangers of first generation or older antihistamines. In the pharmacology community, in the allergy community, we've known it for decades. But it took getting a bigger and younger board of directors to get some inertia overcome to write that paper. So just a little bit about what do I mean by first generation versus second generation, or you can also just say older versus newer. So the problem is that everybody assumes that all antihistamines have been proven to be safe and effective. And that's actually wrong when it comes to these older agents. They were introduced decades before clinical pharmacology studies were required by the regulatory agencies. They were so-called grandfathered, if you will, so they existed. And then the FDA came along and started asking for studies to be done to prove a drug is safe and effective. But if it already existed on the market, they didn't have to go back and do trials to prove it was actually safe to use. Whereas all of the newer antihistamines, or the so-called second generation antihistamines, they have been forced to do systematic and thorough investigations, which is what we would all like to see. We want to know that a randomized controlled trial has been conducted to prove it's actually better than placebo and that it is actually safe. So you can see that antihistamines in Canada have a very long history, and in general in North America. And these are listed based on terms of whether or not they have side effect profiles that we have to worry about versus the ones that just work as antihistamines. So you can see all of these older agents, starting with Benadryl and going all the way back to when they discovered the histamine receptor in the first place. They all have sedative activity, and they have activity against other receptors in your body that cause a different pile of side effects. So you can see here diphenhydramine, or Benadryl, was approved for use in the United States in 1946. Again, it was when they got approved by the FDA, but it was grandfathered. Chlorpheniramine, that's chlortripalon, as you might recognize. Hydroxyzine, the brand name is Atarax, that may be familiar to some of you. There are two early second generation antihistamines that were associated with a few side effects. So they've been taken off the market now. But all of these other ones that you can see, cetirizine, which is Reactin, fexofenadine, which is Allegra, loratadine, which is Claritin, desloratadine, which is Arius, have all been around since the early 90s, early 2000s. And just recently, we finally had two new antihistamines added to the Canadian market, which are available by prescription only. In Canada, they were approved in 2016, but they've actually been around for a long time in Europe. So you can see Rupatadine, which goes by the brand name Rupall, has been on the market in the European Union since 2004. And Bilastine, which goes by the brand name Blexten, has been around since 2010 in the European Union. So they're maybe new to us, but they're not new antihistamines globally. So again, why do we worry about first generation antihistamines, or the older ones? So first and foremost, they love to get into your brain. They have a high affinity for receptors for antihistamines that histamine receptors that are in your brain, and that leads to issues with decreased alertness. It actually can impair cognition. They can impair learning, they impair memory, and impair psychomotor performance or driving, particularly is what we worry about. And the problem is yes, they cause sedation, but some patients will tell you, well, it doesn't make me sleepy, but they still have all of those other problems, even if they don't feel like they're sleepy. I mentioned to the fact that they cross-react with these different receptors that are muscarinic receptors. These cause side effects like dry mouth, urinary retention, and an increased heart rate. They cross-react with serotonin receptors, which lead to increase your appetite and therefore weight gain. And there is actually an antihistamine in the States that's being sold, an old antihistamine being sold deliberately to cause weight gain. It can also interact with receptors that are on your blood vessels, leading to dizziness, and you drop your blood pressure when you stand up. But most importantly, what a lot of people don't know is they can interfere with cardiac ion channels and can lead to arrhythmias and heart problems. So there's 1,000 reasons not to use these older antihistamines, particularly when we have so many more effective newer ones. To that point where all of the things you see over the counter, like Nitol, Sleepy's D, they're all Benadryl under a different name because they are so strongly sedative. They're sold as sleep aids. And the dose that they use for sleep induction is the same as what you would take for allergic rhinitis or an allergic reaction. Interestingly, though, even though they cause sedation, they don't give you a high quality sleep. So you wake up the next day feeling more groggy, you have sort of hangover effects, even with just one dose. So it is one of these things that we try to tell our patients, yes, it'll put you to sleep, but it's not a good sleep. And here's why. If you have a normal night's sleep, while you're awake, you fall asleep, you go into REM sleep, which is when you dream. But if you are awake and you take a first generation or an older antihistamine, you take longer to get to that REM stage and you get a lot less of it. And that's why you wake up more drowsy than you were if you had not taken it. And you may not even fully appreciate it until you actually stop taking these older antihistamines and you realize you have more energy and alertness through your day. Recognizing that this study was done in a different indication other than anaphylaxis. This is obviously done in an allergic rhinitis study, but just to have more evidence that taking these older antihistamines can impact school performance. So again, when you think about children who might be taking something like Benadryl at noon because they had a mild reaction, then trying to go back to school, they may not do as well at school in the afternoon because they're going to be sedated and they may not perform as well on exams or just generally not be able to pay attention in class. So I won't dwell on this too much, but it is important to recognize that these actually have some significant issues with injuries and fatalities due to car, plane, and boating accidents. It's an interesting study that compared a dose of Allegra, a dose of Benadryl, and letting people drink alcohol to the point where they would have blown over the legal limit, and a placebo. And the driving performance of all of these different arms was actually the worst after a dose of Benadryl. And that self-reported ratings of feeling drowsy was not predictive of that level of impairment. So taking a dose of Benadryl actually impaired your driving ability worse than higher than the legal limit of blood alcohol. So despite the fact that we do have these warnings that Benadryl may cause drowsiness and should not be taken when operating machinery, a lot of people forget that an automobile is a good machine. So when we actually did a review of 484 fatalities in Ontario, of the drivers who were killed in car accidents and found to be at fault for the accident, were 1.5 more times than others to have been under the influence of Benadryl or similar older antihistamines. And again, in other countries, they've gotten on the ball, right? So the European Union has labeled Benadryl a Category 3 drug, which means it is likely to produce severe effects on fitness to drive. And it carries the warning recommendation, do not drive after you take this. Seek medical advice before driving again. Another study that was looking at fatally injured civil aviation pilots in the United States, so just about over 6,000 fatal accidents from plane crashes. Of all of the autopsies, Benadryl was the drug found most commonly that was capable of causing impairment. We also have to think about overdose and toxicity. You may have heard of the TikTok challenge, the Benadryl challenge. This is a problem. Benadryl and other older antihistamines are documented drugs of abuse because the overdose symptoms of feeling fevered, feeling flushed, your pupils dilate, Some people interpret that as a fun feeling, especially, maybe teenagers who don't really realize what you're supposed to feel from drugs. Essentially, though, you're going to get into problems with low blood pressure, and they even cause coma when you take overdoses of Benadryl and other older antihistamines. I also see a lot of infants and children who have accidental or intentional overdoses present with paradoxical reactions. So instead of getting sleepy, they actually get irritable, they get hyper, they run around instead of going to sleep. When you take too much, then you actually have risks of hallucinations and seizures. And again, drowsiness, delirium, respiratory depression, and coma can occur. And there have been, this one study that was reported in 2003 of almost 30,000 exposures to Benadryl reported to poison control centers. 40% of those were children under the age of 6, resulting in at least 6 fatalities. So probably not the best drug to have in our medicine cabinet for a lot of reasons. I alluded to the fact that there's issues about cardiac safety. It's an increasing concern with these older antihistamines, particularly in elderly patients who have a lot of comorbidities and other drugs they're taking. And again, when these antihistamines were introduced, they didn't study it because it wasn't known to be a risk. But now that there's more data showing that it's an issue, Health Canada has actually issued a black box warning against Atarax that it can increase the risk of cardiac complications. We now know it to be a class effect of all the older antihistamines, including Benadryl, but this risk does not occur whatsoever with the second generation or newer antihistamines. So what are these newer antihistamines? Again, I went over them briefly, but just to get a sense of, just to help tie the names together, we have Blexten in alphabetical order. So Blexten is available only by prescription. Pediatric dosing has been indicated once the child turns 4 and they're more than 16 kilograms. Reactin is available both by prescription and over the counter. The prescription is obviously a higher dose. It's a 20 milligram dose compared to what you would give over the counter. And it's approved for the use of children 2 years of age and up. Arius is only over the counter, can be given in children 2 years of age and up. Allegra is over the counter and unfortunately is only indicated in 18 years of age and up. Claritin, also over the counter, 2 years of age and up. And Rupall is prescription only, but again, 2 years of age and up, and has the largest randomized controlled trial data showing its efficacy, not just its safety for its 2 indications. So these antihistamines were designed deliberately to have decreased ability to cross the blood-brain barrier, so you don't get the same side effects with that you do with the older agents. These initially became available since 1981. This growing class of medications have all been extensively studied in high-quality, randomized controlled clinical trials. And we've also got studies that show the safety of them, even if you're giving them in high-dose, off-label regimens. So again, in certain circumstances, we do need people to take more than just what the product monograph says, and they're safe to do so. They've also been found to have often faster onset of action, so it starts to work faster than Benadryl or other older antihistamines. Again, there's no such thing as a drug with no side effects, but in contrast to the older antihistamines, they really do have a minimal serious safety concern. No fatalities directly associated with the use of the newer antihistamines. And there have been case reports of accidental exposures of up to 30-fold ingestions of Reactin, Claritin, and Allegra, and none of those resulted in any serious adverse events. Again, the level of sedation experienced by patients taking newer generations antihistamines does vary a little bit by specific medications and the dose that they're taking. So if you look at the Loratadine, Claritin, Allegra, and Arius, they're the sanctioned choices for pilots, truck drivers, and others who perform complex tasks in the US. We don't have Canadian statements in this regard, unfortunately, but if we did, I would include things like Rupall and Blexten in that same category. Compared to cetirizine, which is the most sedating of the least sedative antihistamines. So that's why cetirizine and Reactin is called a low sedating antihistamine. It's not technically non-sedating, where the others are. So again, the use of antihistamines in the emergency department, it's certainly appropriate to be used in acute non-anaphylactic allergic reactions such as hives or swelling. They can be considered a second line supplementary supportive care of anaphylaxis, like to control itch and hives, but again, not to replace epinephrine. And the rule of thumb that I teach to the emergency physicians anywhere who will listen to me is if the patient is well enough to take something by mouth, they should be using Reactine or Rupall. If the patient is in such a circumstance that they need something to be given by an intravenous, unfortunately, Benadryl or diphenhydramine is the only one we have. But if you think the patient's stabilizing enough or they just have hives alone and they can take something by mouth, then use a second generation agent instead. So again, as I mentioned already, antihistamines and anaphylaxis are second line and supportive and do not replace epinephrine intramuscularly. There's a theoretical specific benefit for Rupall because it's a bit unique. It's not only an antihistamine that blocks the histamine receptor, it blocks something called platelet activating factor, or PAF, which is one of those other mediators that I mentioned to you that, again, the mast cell degranulates. It releases a whole bunch of things, not just histamine. PAF is one of the ones that's actually been shown to be quite important in determining the severity of anaphylaxis and allergic reactions. So again, people recognize the name Reactine for the most part, so maybe you don't know as much about Rupall. They're both safe and effective second generation agents. Licensed doses are 10 milligrams and 20 milligrams for Reactine. Again, the 20 milligram is only by prescription, 10 milligrams for Rupall. But again, you can see the Rupall sedation risks are much lower than Reactine. As I alluded to, of all of the second generation agents that are less sedating, Reactine is the most sedating of the non-sedating antihistamines. But there's always going to be individual differences in responses. So these are percentages from clinical trial data. Everybody's going to be a little bit different. Some people will say that 5 milligrams of Reactine snows them. Other people will tell you that everything makes me sleepy. So again, there's always going to be individual nuances. Just as I mentioned, the term Blexten or Belastine, it's also got much lower rates of somnolence or fatigue compared to Reactine. And so again, that's another reason why people complain that Reactine makes them sleepy. This is another good option as well. So in the pediatric population, again, so far the indications for these are for allergic rhinitis and for urticaria. But I think it's important to realize that they will treat symptoms of hives and itch for anyone who is 2 years of age and up. But and I think the important thing is for Rupall, it's actually got a lot of clinical trials supporting this. Blexten has been approved for the use in children in Canada as well. Again, 4 years of age and up if they weigh more than 16 kilograms. But this has been determined by safety data analyses as opposed to efficacy. They enrolled 409 children ages 2 to 11 with either allergic rhinitis or urticaria, treated them with Blexten versus placebo for 3 months, and just looked at safety and tolerability, and there was no differences in safety outcomes. So because it was shown to be safe, Health Canada approved it for allergic rhinitis and urticaria. When you look at the data from Rupall, again, lots of numbers for this in the pediatric population. But importantly, when we look at how much it's been studied in urticaria in the pediatric population, which is what you're going to use it for, granted this is for chronic spontaneous urticaria, but you're treating hives, lots and lots of people in their clinical trial programs compared to, you can see a paucity of data against the other antihistamines that we recognize in the market in the pediatric population. So again, when we go back to what happens with the immunology of a food allergic reaction, you've got that mast cell degranulation, which drives all of your downstream symptoms. This is just to show you that PAF is released early, but then it also comes into play later. So there is a theoretical benefit of blocking PAF if you're going to take an antihistamine as an add-on to your epinephrine. And the reason, the other sort of data that supports this, if you look at patients who are having acute allergic reactions, they have a lot higher levels of this PAF molecule compared to non-allergic controls. And the amount of it goes up the more severe your reaction is. So again, fully off-label. It's not indicated, but it's something that I think is a useful add-on to epinephrine in the setting of anaphylaxis. So again, I'll say it, if you say it 3 times, maybe it'll finally sink in. Epinephrine is the mainstay of treatment for anaphylaxis. Antihistamines are only going to help with hives and itch. The Canadian Society of Allergy and Immunology no longer recommend first-generation antihistamines such as Benadryl for anything. Rupall, Blexten, and Reactin are safe and effective oral options for allergic conditions, which may be covered by your drug plan, which does help to save some of that out-of-pocket expense. But we also have lots of over-the-counter options as well. Arius, Claritin, Reactin, Allegra, and generic versions of most of them as well, which generics tend to be a little bit less expensive. And if you're ever confused or concerned, you got to make sense of that antihistamine aisle. Your friendly neighborhood allergist is always here to help if needed. And with that, I will thank you very much for your attention, and I look forward to our discussion.
Terrific. Thank you so much, Dr. Ellis. Time for the questions that were pre-submitted as well as those that have come in during the session. So, okay, so let's first start with the group of questions that were really around signs and symptoms of anaphylaxis. Maybe you can just start by reminding us again, what are those signs and symptoms and how do we determine if we're dealing with anaphylaxis?
Yeah, so it's important to realize that because anaphylaxis is systemic, you're going to have lots of potential symptoms that could occur, alone or in isolation for each of the different organ systems. So common things would be hives and swelling of the lips, tongue, or throat, a sensation of itch under the mouth or in the tongues. We can have a difficulty breathing, manifested as just either cough alone or sometimes chest tightness and wheezing. GI symptoms include nausea, vomiting, abdominal pain, diarrhea. You can have issues with even minor things in the upper airway. So early symptoms might include sneezing and that sort of thing. And that's one of the things we pick up on after we give an immunotherapy injection, for example. If somebody starts to have a sneezing fit after I just gave them an allergy shot, I'm hovering to see if anything else is going to happen. But it's important to realize you have to have at least 2 of those organ systems involved. You wouldn't just, abdominal pain alone, that's not anaphylaxis, right?
Okay, now what about in terms of the skin, right? Because when we think about systems or symptoms, right? Sometimes people are thinking 2 symptoms. So for example, if someone reacts with lip swelling and another skin symptom,
that doesn't count.
That's one system, correct?
Correct. Yeah.
Okay. Okay. So so you're looking for, and I think that's important, and we'll make sure that people are familiar with our description of its skin. When we're talking systems, we're talking skin is a system. And so that's got both the swelling and hives in it. We're talking respiratory as a system. We're talking gastrointestinal as a system. So again, if I have an itchy mouth, right, and a hive, we're still talking that's one system.
Correct.
Okay. But if I had a runny nose and an itchy mouth, then we're talking 2 systems.
Yes, that's 2 systems, but that's sort of in the milder stages. So that might be early presentations. Right. Yeah.
Okay. So I guess it's always that fine balance of when should you use epi, right? Yeah. And so maybe you give us your thoughts on just that. Like you've probably had lots of patients saying, okay, well, I'm struggling on when to use. Just maybe if you can kind of give us your view of how you talk to patients about that.
Yeah. So first and foremost, there's very little downside to giving epinephrine intramuscularly. It is safe. So there's no wrong answer for, oh, I had hives and lip swelling only and I wouldn't use my EpiPen. Is that a bad thing? No, if you thought you exposed yourself to your allergen, that's safe to do. But it's more clear cut when you have clear symptoms in 2 organ systems. So if you break out in hives and you've got difficulty breathing, that's a no-brainer. You should use your epinephrine.
So when it's not a no-brainer, it's kind of like, you know what, feel free to use it if there's no downside.
Yeah.
All right. Yeah. Okay, perfect. Okay, is there an age at which anaphylaxis typically presents? Like, is this something we're more likely to see in older children than younger children? What's the research tell us on that?
So anaphylaxis can really develop in theory at any time. It is more common to be food allergy, for example, is more likely to be diagnosed in childhood. Now that we're doing more early introduction of highly allergenic foods, which is known to reduce the risk of peanut allergy, for example, we are going to see a little bit more development of peanut allergy. It doesn't prevent it, but we will see a little bit more issues with anaphylaxis even in the infant population. But most commonly, you start to see this more around age 2 to 5, I would say, as your first presentation. People can develop late onset food allergies, though. So I see a lot of people in their 20s and 30s who, out of the blue, develop a shellfish allergy. And I don't have a good explanation as to why that is, other than I do recognize that it happens. So there's no upper age limit, if you will. But most commonly, it's in the preschool age, I would say.
Okay. And then is there a chance of anaphylaxis during sleep?
No, because if you're asleep, it means you're probably well after 1 to 2 hours of your last ingestion or exposure to anything other than what's in your bed. There is the exception if people are really going through the archives of the internet. There is this concept of red meat anaphylaxis that can occur due to an issue with people who have been bitten by the Lone Star tick. That can manifest as a late onset anaphylaxis up to 6 hours after ingestion of beef or pork. But we don't have that tick in Canada, and it's a very, very rare condition to have. So that's so-called alpha-gal allergy that you may have read about. Eventually, we probably will have it in Canada, but right now we don't. So if you may wake up with hives or swelling for some other reason, but it's probably not anaphylaxis.
Now, there were a few questions that were submitted. We've talked about this one system, one symptom concept. But does this advice differ if someone is on OIT? So if someone is on OIT and has oral immunotherapy, for those that may not be familiar with the term, would you recommend interpreting that as anaphylaxis or taking action on that? Because it is a known ingestion.
Yes, exactly. So again, if you are taking something deliberately that you know you're allergic to in order to try to desensitize yourself, we tend to treat very early in that circumstance. So we sort of treat pre-anaphylaxis, just because we know we're exposing you to something that you're allergic to, and it's a known complication or side effect of the therapy. So our threshold for treatment is much lower in that circumstance compared to I just got stung by a bee, now what do I do?
Okay, terrific. Now we're going to move on to questions related to antihistamines. And I know some of this you covered off in the content of your presentation, but I think it's worth restating some of these things just for, added reinforcement of the key messages. So should antihistamines be used along with an EpiPen, an epinephrine autoinjector for severe reactions? So, and we're talking in this case, anaphylaxis. Should they be used in conjunction?
Yeah, I think it's quite reasonable to use them. If for some reason you don't happen to have an antihistamine with you, but you had your epinephrine autoinjector and you just give yourself your epinephrine, you didn't do anything wrong. So it's a second line optional add-on therapy. But as long as you're using your epinephrine and you're itchy or you just want to have some extra antihistamine on board just in case, that's fine, as long as you're not taking the antihistamine and hoping for the best.
Okay, so now sometimes we hear, though, in the messaging that's out there in the world, that antihistamines can mask the reaction. So if the epinephrine wears off, right, or does it wear off? What's the life of it? And then would we be setting ourselves, is there some basis to this idea that antihistamines can mask anaphylaxis?
So that's a myth that we thought we busted a long time ago, but obviously it's still out there. Where antihistamines are not strong enough to hide anaphylaxis. Anaphylaxis is a severe enough reaction. It will come out. You will see it. Okay.
Now, what if someone is taking antihistamines in a day to deal with, maybe they've got allergic rhinitis or dealing with seasonal allergies? can they still use 1 or 2 doses of epinephrine?
Epinephrine or an extra antihistamine?
No, can they? Well, some of them is can you use an extra antihistamine, but in this case, it doesn't change the impact of epinephrine using an auto injector.
Yes, no, absolutely. If you are taking a daily antihistamine, the epinephrine
Yeah.
will still work. Yeah.
Okay. Okay. And then I guess specific to Benadryl or diphenhydramine, like, does it have any role in allergic reaction and anaphylaxis? I mean, I think the message seemed quite clear,
Yeah.
Dr. Ellis, but is there, when you take a look at this, does it have a role?
I think no, quite frankly. As I say, if you feel like you want to give somebody an antihistamine, you should give them a second generation agent. The only time that you might ever, not fault somebody for giving Benadryl is when you've got a very severe reaction and you're putting in IV lines to help treat their severe anaphylaxis. You're starting to give them epi every 5 to 10 minutes, whatever your current protocol is. When you've got an IV and you don't think the patient's well enough to swallow something by mouth, then you're stuck with Benadryl. But otherwise, most patients, if they're getting their epinephrine, things are sort of starting to settle down. They're probably well enough to take a pill. And these newer antihistamines have a fast onset of action, anywhere from 30 minutes to 45 minutes, whereas Benadryl can actually take 45 minutes to an hour to kick in when you take it by mouth. So there's that. A lot of patients say to me, well, why does it seem like Benadryl works faster for me than Reactin or Claritin? I said, because you feel the side effects first. It goes straight to your brain, so you feel something. And that's why people think it's working faster, because they feel something, but really what they're feeling is the CNS side effects, not the actual antihistamine effects.
Right, and maybe calming you down.
Yeah,
right?
it's sedating you,
Like
right? So
yes. I know, the Benadryl to the child, it was always like, well, it seems to calm them down. Well, hearing what you've told us today, it's not a surprise because it might be a little cocktail that we're serving to our children. Yeah. Okay. So when are antihistamines indicated in patients with known anaphylactic allergies? So like, is there a role there for taking those as sort of a pre-exposure type of regiment?
So again, I think that's when we would talk about things like in OIT, for example, you might have people on a background antihistamine to help minimize the symptoms associated, like local symptoms. But really, for the most part, the only time antihistamines are actually effective in preventing anaphylaxis is in very unique circumstances related to non-IgE mediated reactions, such as people who are allergic to radio contrast media or contrast dye, in which case then, because that's not IgE mediated, you actually can prevent it because you can just do things to help make the mast cell not have that issue. Because it's not due to an allergy per se, it's due to the physical chemical interactions of the contrast media with your mast cells. So that's why you can prevent those ones. But something like taking an antihistamine daily to prevent a food allergic reaction, I wouldn't recommend that.
Okay. Okay, the next suite of questions are more around emergency department related questions. So in this situation, the person is asked, after administering epi with long wait times in emergency departments, what are the steps that one should take while waiting to see the doctor? What should they be watching for?
So first and foremost, one of the things that I want to make sure people are not doing is avoiding using epinephrine because that means they have to go to the emergency department. So they're not taking their epinephrine because they don't want to go to emerge. So I want to make sure that I sort of dispel that myth. If you've used your epinephrine and you're getting better and everything's settling down, you don't necessarily need to go to the emergency department. As long as you're feeling better, you've never had severe reactions in the past. And that's something that, because the reason why the product monograph tells you to go to the emergency department is you might need another dose, as opposed to something bad might happen to you because you just took epinephrine. So I do give some of my patients permission to use their epi at home, wait 10, 15 minutes, if you're getting better or things are settling down, that's all you need to do. You can just obviously watch for those exact same symptoms to come back. And if they start to come back, then now you've got to use your second epi and off you go. Patients who have had histories of very severe reactions, I don't give that permission to. Again, it's a shared decision-making discussion that I have with patients just to make sure that I'm choosing the appropriate person for that permission for at-home management. And the CSACI is actually going to be releasing a position statement that deals with this very issue in the coming months. But to answer your question of I use my epi and now I'm sitting in the triage or I'm sitting in the waiting room or I've got an over room but I still haven't seen the doctor, you're going to watch for the exact same things that prompted you to use the epinephrine in the first place. So all of those same symptoms that we've already highlighted are signs of anaphylaxis. If any of those things start to come up, that's when you want to ring the bell and get somebody's attention. If you run out of your own epinephrine auto-injectors and you know you need something for the emergency department to do. I mean, I realize that emergency departments do vary across the country in terms of their responsiveness, but most of the time, if you tell people I have a peanut allergy, I just had an accidental ingestion, I had anaphylaxis, I use my EpiPen, I need to be seen. Our emergency department anyway will listen to that and bring you right into one of the more monitored areas of the department.
Okay, now on this second dose, use of a second dose, like how long do you sort of wait to see whether the first dose has been effective before you decide to use a second dose?
If you haven't seen any improvement at all within 5 to 10 minutes, give another one.
And is there any stats, Dr. Ellis, around how many allergic reactions really resolve? Like, is it more common that an allergic reaction resolves after a first dose?
Yeah, so there's actually just been a review article, a systematic review of the literature published by Paul Turner out of the UK, showing that the risk of needing a second dose of epinephrine if you can extract it from properly conducted studies is probably no more than 10%. So anecdotally, we all know somebody who needed 3, 4, 5 doses. But in the literature that's out there when you can extract it from a trial, it seems to be a little bit lower than what your anecdotes might have told you.
Okay, now on, this is not so much about ED. Well, it is. It's remote locations because you're in a situation where you're not close to an emergency department. And you won't be able to get timely access to medical help. What's your recommendation? What do you recommend to your patients in this scenario?
Yeah, so those are the patients where, thank goodness for OHIP Plus for children covering the cost of these epinephrine auto-injectors. That's when I would have, a good armamentarium available, a minimum of 2 epinephrine auto-injectors if you're quite remote. And it just depends on the severity of their first reaction. If these are people who have had, hives only, and I've confirmed their allergy from skin testing, and we haven't had a chance to bring them in yet for an oral challenge to see if this is really a concern. Again, in remote locations, it's even worse because there's probably no allergists up there anyway. But those are the people that probably warrant, 2 or more epinephrine auto-injectors to have while they're waiting for transport to the nearest urgent care center.
Okay, and in that situation, the antihistamines as an add-on?
Yeah, that's when I would, it couldn't hurt. It's, like I say, antihistamines don't replace epinephrine, but it would be worthwhile adding them in to at least get your hives under better control, because that's one of the things that does become very uncomfortable and can drive anxiety levels higher when you're really, really itchy. So that's where antihistamines can be helpful for sure.
Okay, now and on that, once you've given someone has administered an epinephrine auto-injector, like some of our audience will have had that, they've had that happen, right? They've had to administer. And then there's a number that they've never had to, but there's that fear. What do they experience when the epinephrine is given? Like, what's the sense that, that people should be prepared for so that they're not concerned about, oh my gosh, is this really what's supposed to be happening?
Yeah, so there's common side effects of epinephrine, but they're transient, right? So I'll give a personal example. I accidentally injected myself with a real EpiPen when I thought I was handling a trainer. So I'm not having any allergic symptoms whatsoever, and here I go and I just gave myself a full dose of Epi. So within 1 to 2 minutes, my hand was shaking. I could feel my heart rate had picked up. So tremor, palpitations, feeling a little bit dizzy sometimes, anxiety can be a common side effect, but they all go away within half an hour. So yes, I was a little bit shaky for half an hour. People were laughing at my handwriting, but it all went away within half an hour. So those are the kinds of things. So if you feel like it made you shaky, it made your heart race, that's normal. That's a sign that you've actually got a good enough dose to get something.
Right.
Those are side effects you actually want because it shows you've got the effect as well.
Now, any advice for the parent that has a child who resists the use of an epinephrine auto-injector?
So that's where I would actually favorably recommend Allerject over EpiPen because it's a slightly smaller needle and it's less pressure to make it fire, and so it's less painful. So again, I've deliberately administered an expired Allerject for myself so I could be able to describe it. It's less pressure to make it go off and fire, so it doesn't hurt as much. So that helps to and the other thing is there's this temptation that, oh, because you've got to hold it for 10 seconds and then the kid starts wiggling and you try to hold them still or hold them down and give the that's not actually necessary. The product monograph has been changed now to 5 seconds. It's really probably more like 2. So we say 5 seconds to be on the safe side, but it's in the body like within 2 to 3 seconds at most. And again, you just want to make sure that you're not, wrestling the child too much, because then that becomes a bit of a traumatic experience for the child. And there's efforts to develop needle-free epinephrine, but they're slow to come, unfortunately.
And I guess that what you were talking about earlier in terms of, coaching the child through, here's what's going to happen. So this is how you're going to feel this. And that means that it's working is probably really reassuring as well.
Yeah. Just it's going to be a little pinch, but then it's going to help you feel better.
Okay. Now, what's your recommendation on the number of devices people should carry?
So again, I gauge it based on what was the severity of their initial reaction, and I already alluded to distance from medical care. So if you've had a good and rip-roaring anaphylaxis and or you live far away, which is a lot of the patients that I serve actually, I have a huge catchment area geographically, then those people want to have 2. People who have just had a milder reaction or they didn't even quite meet the definition of anaphylaxis, but they were close enough. I'm like, yeah, you never know what's going to happen next time. I'll just give them 1. Cost is an issue sometimes if you don't have coverage, that window where the depending on the province, I'm being very Ontario-centric, but generally speaking, specialists can get access to physician samples so that we can help support those patients who can't afford to buy an epinephrine auto-injector.
And then plane travel, is it 2? Would you if you're on an extended plane ride, what's your recommendation there?
Yeah. So first and foremost, just to let you know, you don't need a letter from your physician to give you the right to carry an epinephrine auto-injector. I have 3 in my purse and I fly all the time. I don't need them for myself. I have them because I would feel horrible if I witnessed a acute allergic reaction and I couldn't do anything about it. So I would say, aside from cost, it might give you more peace of mind to have 2.
Okay. And can the devices be used past their expiry date?
Great question. So it's certainly safe to use an expired epinephrine auto-injector, unless when you're looking at the little clear window on the front of the device, if it's not clear anymore and the liquid is brown, you definitely want to throw that one out or to hand that one into the pharmacy for safe disposal. But we do know that at least up to 6 months past the expiration date, it's still going to have at least 50% of the dose that's in it. It's probably higher than that. But there have been some extra data produced showing that even expired devices, they're still effective. They're just, you prefer that you use the one that's in date. But if you use one that's in date and then you're still having some issues, go ahead and use one of your expired ones.
Okay, so I want to get to our last big question here, because we did start the topic on, talking about Benadryl, and there was great insights in terms of the second generation antihistamines. But like, why is it that we this confusing messages? The pharmacist said use Benadryl. I heard from my family physician, just use some Benadryl. Like, why is it still recommended in so many healthcare settings? And what's your vision of where it should be on this topic?
As I alluded to already, I would really like to see it be something that moves behind the counter, so that if you're one of the rare people for whom I know a second generation agent wasn't effective, or you really can't afford a second generation agent, at least if it's behind the counter, you have to have a conversation with the pharmacist about whether or not it's actually safe to use. We're seeing this. There's a chance that one of the anti-allergic medications in the US is going to be recalled from the market because they've shown it doesn't do anything. So those are the types of conversations that I think would be very helpful at the pharmacy level and the Health Canada level. Is these are not necessarily safe drugs. I don't think they should be over the counter personally. So I would love to see them either removed from the market or at least moved behind the counter. Why do we all know it so well? Why is it the one that gets recognized? It's just brand recognition. Great marketing from the original manufacturer. Great lines on the TV ads you see from the States, give them the drill. It's kind of like it's become the Kleenex of antihistamines, right? We don't say tissues anymore, we say Kleenex. We don't say auto injector, we say EpiPen. It's just that kind of, it's that brand name recognition. Everybody thinks it's the best stuff because it's been around the longest, but sometimes that's not actually the case.
Terrific. Well, listen, Dr. Ellis, thank you for taking the time to walk us through this. You're very passionate about the topic and very knowledgeable about the topic, and I know you're an extremely busy person, so we appreciate you taking the time to share your insight. So I'll ask you to turn off your camera, but I just wanted to make sure that you know that we're very grateful for your participation.
Well, thank you very much for having me.
All the best. Okay, so just a few things on what's next. As a reminder, you will get a short survey through GoToWebinar immediately after this webinar that will pop up on your screen. You'll also receive a survey in an email in an hour or so. Please take a moment to complete it, because your feedback is crucial to helping us improve our future webinars and also to better understand the additional questions or comments you may have. So we've compiled our key anaphylaxis resources for you, and you can access them at foodallergycanada.ca/anaphylaxis resources. On this page, you will find resources and videos that show you how to administer Epi, webinars that go into more detail on signs and symptoms, free online training with Allergy Aware, and a link to our anaphylaxis resources for schools and healthcare professionals. Also, be sure to check out our back to school resources at foodallergycanada.ca/back to school. Although our campaign is ending this week, you will still be able to access this section over the fall and winter. We also have more webinars coming up before the end of the year, so please be sure to visit foodallergycanada.ca/events to register now. Our next one, in fact, is only 2 weeks away. Lastly, we would like to thank our back to school campaign sponsors for this event: Allerject, the Peanut Bureau of Canada, Chapman's Ice Cream, and EpiPen. Thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share this with others who may benefit from this content. This now concludes our webinar.